Hello, everyone, and welcome to What Next? What Happens When Treatment Ends? We're glad you could join us today. My name is Elaine Gonzalez. I'm the community educator at the Breast Cancer Resource Center, or BCRC. I'm pleased to serve as your moderator today. The Breast Cancer Resource Center, BCRC, is a community-based nonprofit serving Central Texans impacted by breast cancer since 1995. Strengthened by our mission to empower those affected by breast cancer with personalized support and compassion, and in collaboration with our community partners, BCRC envisions a future where no one faces breast cancer alone. BCRC offers patient-centered care from diagnosis through treatment and into survivorship. Through its two pillars of support, guidance and education, BCRC certified patient navigators, whom are all breast cancer survivors themselves, empower those touched by breast cancer to become active and knowledgeable participants in their healthcare journey. This program is provided as part of a cooperative agreement awarded by the Centers for Disease Control and Prevention to expand our programs for young women. The purpose is to increase the availability of supportive services for young breast cancer survivors, young women with metastatic breast cancer, and their caregivers and families. The CDC funding continues today. We are so honored to have with us today Dr. Kathryn Hudson. She joins us from Texas Oncology Austin Central. Thank you, Dr. Hudson, for joining us today. I am going to stop sharing my screen and I will turn things over to you.
Welcome, everybody. I'm so honored to be talking to you all today about the issue of survivorship. It's really cool to see some people from outside of Austin and outside of Texas. So it's just a testament to how wonderful the Breast Cancer Resource Center is here in Austin and how they've really extended their reach. And I'm honored to work with them quite often. So I'm a medical oncologist, and I am also the medical director for Texas Oncology of Survivorship. I joined Texas Oncology about 6 years ago. I moved here from North Carolina, and I love being in Austin and taking care of all of our wonderful patients, which I think of as an honor. So today we're going to talk about survivorship, what happens when treatment ends. Okay, so think back to when you or your loved one was diagnosed with breast cancer. It's a really stressful time and you're bombarded with information and you're so focused on the next right step. You know, who are your doctors going to be? What kind of surgery you're going to have? Are you going to have a lumpectomy or a mastectomy? Do you need more biopsies? Are you going to have radiation? Are you going to have chemo? What's your long-term prognosis going to be? And that's only the medical stuff. Then you're also thinking about how's your family going to react? Many of us are caregivers for other people. How can I take care of my kids? How is this going to impact my marriage? How is this going to impact my work if you work? What about overall health, finances? So there are all of these things that happen at the start of the breast cancer journey. And then you kind of start on your path. And then you're just kind of trying to get through everything, be it surgery or chemotherapy or radiation. And you're kind of having one foot after another, and you're seeing your team all the time. And then what happens? You finish your active treatment, which usually means in our world, surgery, chemotherapy, radiation. And then you go on to the more chronic phase for a lot of you. And congratulations, you're a survivor. It's over. I think we all know that it's not really over, but it's a really difficult transition because you're not seeing your team as often. You may have been coming in all the time for treatment, and then all of a sudden you're not coming in nearly as often. And I think a lot of survivors, and I think a lot of caregivers or family members or friends just kind of want to think, oh yeah, that's behind us now. It's over. Now we're going to go back to the way things were before. Life is going to be wonderful. I don't need chemo anymore. I can feel better now. And unfortunately, that's just not the reality. I think most people do feel a whole lot better, right? But you just can't go back to the person you were before. You're a different person after you've been through cancer and treatment, physically, mentally, emotionally. Relationships change, marriages sometimes change. Your ability to work could have changed. So it's a transition where you're trying to figure out who you are at this point. What does all this mean? And then all of a sudden the future stretches out ahead of you and you're wondering, how is this going to work? And then all these other feelings flood in, like fear of recurrence, which I'm sure everybody deals with. And it's really difficult. And also, gosh, I'm having these symptoms, or I have to be on these meds for sometimes up to years. How is that going to affect me? And how am I going to feel? Or I still have symptoms from chemo. Like, when is that going to go away? What is my relationship now with my oncology team? What about my primary care doctor, who often has like faded into the background a long time ago? So all of these, it's a different ball game once you've entered into this period. So that's what we're going to talk about today, and what happens then. So what is survivorship? What is a cancer survivor? There are all these official definitions here that you can see on the screen. Basically, it's anyone who has ever been diagnosed with cancer. And actually, the National Coalition for Cancer Survivorship has included family, friends, and caregivers of those who've had cancer. So really broad definition. Does the definition really matter? No. And then for those who may be wondering, this also includes people with metastatic cancer. So anyone who's ever been diagnosed with cancer, and even their caregivers, are included in this definition. This is so important because we have so many survivors now, which is a wonderful problem to have. I think the field of oncology, one reason I love survivorship is because now that we have so many survivors, we're realizing it's so important to change our focus for the long term. The historical field of oncology, research-wise, has been so focused on how can we get more people cured? What's the best surgery to do? How can we cure? Sometimes, especially way back when, that's happened at the extent of, or at the expense of toxicity. And actually, the history of breast cancer is a whole nother topic that's fascinating. If you all haven't read about it, you should. There's a great book called The Emperor of All Maladies, which is about the history of cancer in general, but there's a great chapter in there on the history of breast cancer, and it's fascinating. But we've come a long way in breast cancer care, especially. We have so many breast cancer survivors, so many cancer survivors in general. You can see 2022, we have 18.1 million cancer survivors in this country. So we need to not forget, of course, about how can we cure the most amount of people, but also really strongly think about how can we keep people healthy and well for as long as possible, right? Because that's the goal. We don't want to cure people of cancer so they can feel miserable for the rest of their lives. Quality of life is really important. Overall wellness and health is really important. So survivorship, to me, is really focusing on those things. After primary cancer treatment is over, how can we maximize wellness and also try to make sure cancer doesn't come back? So there are 4 key areas of survivorship care as defined by the Institute of Medicine. 1, prevention of recurrent and new cancers and of other late effects. Surveillance for cancer spread, recurrence, secondary cancers, and assessment of late effects. Number 3, intervention for consequences of cancer and its treatment. And then 4, coordination of care between specialists and primary care providers. Because hopefully you don't need to see your oncologist for the rest of your life, although sometimes we oncologists would like that. And so if you look to the right of the screen, there's this wheel of survivorship wellness. So these are all the things that are incorporated into wellness and survivorship. So emotional, spiritual, sexual wellness, goal setting. How can you be as healthy as possible? Which incorporates nutrition, physical activity, managing stress, and sleep. So for many, depending on where you're getting your care, at the end of your primary treatment for breast cancer, that is when you can get a survivorship visit. That's how it is in my practice. So a survivorship visit is when you meet with your provider, or in our practice, it's the nurse practitioner or physician assessment or assistant, and you go over everything that's happened to you during your diagnosis and during your treatment. So what kind of surgery did you have? What did the pathology show? What kind of chemo did you get? And then, and that's put into a document called the Survivorship Care Plan. And then what's talked about for the rest of the visit are all of these things. So how are we going to monitor for recurrence? How are we going to manage and monitor psychosocial and medical late effects? How are we going to screen for other cancers? Education on a lot of things. Readdress genetics. Hopefully that's addressed at the beginning, but oftentimes this is the time where you discuss it again if needed. Coordination of care. It's a time of empowerment of survivors to really advocate for your own needs, seek the other care you need to be as well as possible. Talk about diet, exercise, how to be as healthy as you can, and then provide resources to assess with financial insurance issues, which are the issues we all hate the most. So I'm going to talk about a lot of these different topics and give you more information on them. You know, a lot of these things would be touched upon in a survivorship visit if you have one. So once you've had breast cancer, it's important to monitor for a second breast cancer. Unfortunately, especially if you still have your breast tissue, it's possible to get another breast cancer. And so, as all of you I'm sure are familiar, we recommend mammograms if there is residual breast tissue, meaning you didn't get a mastectomy. This is a common question. What kind of mammogram should I get? There's this thing called the diagnostic mammogram, and then there's a screening mammogram. So typically, most women get a screening mammogram. Now, the difference between a screening and diagnostic mammogram is the number of views that they take, but also in the diagnostic mammogram, the radiologist is focusing on like one area. So, for example, many of you probably had your screening mammogram when you were first diagnosed, and then they saw something, and then they did the callback mammogram or the diagnostic mammogram, where they were really honing in on one place. So that's really the main difference. So after breast cancer diagnosis, there's not a consensus on what kind of mammogram you should get afterwards. I would say most of us probably do a diagnostic mammogram for the first couple of years to get extra attention to where your cancer was, to really assess that area for any kind of residual or regrowth of the cancer, which is very rare. I mean, 4% or less of survivors that happens to. But so that's the point of that. They focus on that area. They might get 1 or 2 extra views. And so what I do in my practice is I'll do a diagnostic mammogram for 2 or 3 years after the breast cancer treatment, and then I'll go back to screening mammograms because we're not as worried about where that cancer was. Another common question is who should get MRIs of the breasts? Now, MRIs are not fun, and they're a blessing and a curse. It's a blessing because they show every little thing. So they're not the end all be all. We use them for different things, but the MRI of the breast are recommended for those with certain gene mutations, especially BRCA. Those who have a particularly high risk because of their family history, or if they have very dense breasts. So in Texas, there's now a law that says when you have your mammogram report, the radiologist has to comment on the density of the breasts. And most women have some density, increased density. So you might see heterogeneous dense breasts, you might just say dense breasts. The MRI of the breasts are indicated if it says very dense breasts. So that's a common question. And physical exam is still really important. Your oncologist or your primary care doctor or somebody should be examining your breasts every 6 to 12 months. A lot of things are picked up on physical exam. And then, of course, do your own self-breast exams. Okay, what about imaging after mastectomies? If you've had a bilateral mastectomy, this is a really common question because it's really hard to not get mammograms anymore. What's important to know about mastectomy is that it's impossible to remove all of your breast tissue. They remove as much as they can. They remove almost all of it, but believe it or not, you have some breast tissue that can grow up into your, upper chest area, under your arms, sometimes even into your abdominal areas. So it's impossible to really image all of your breast tissue. But if you've had mastectomies where, more than 95% of your breast tissue has been removed, it is not recommended to have mammograms or breast MRIs. And I know this can be difficult to really get. So this comes from this large study that analyzed 16 smaller studies in patients who had breast cancer, who then underwent bilateral mastectomies with or without reconstruction. They had two groups of patients. One group was getting mammograms, ultrasounds, MRI. The other group was just getting physical exams. And the cancer detection rate with all of that imaging was less than 1%. So what this means is that that imaging really wasn't adding anything. The majority of cancers that were detected on physical exam. That's why physical exam is so important. So that's why imaging after mastectomies is not recommended. Now, of course, there's always exceptions to every rule, especially if you've had a deep flap or fat replacement surgery. It's pretty common to have what's called fat necrosis. It can feel lumpy, bumpy. And so if you come in with something like that and we're concerned, we could always do an ultrasound, to take a look at what that is. And 9 times out of 10, even higher than that, it's what's called fat necrosis, which is just some inflammation of the fat there. So really rare to get another breast cancer after mastectomies in general. Okay. Monitoring for distant recurrence. So this is a separate beast, and this can be really confusing for a lot of people. So I always try to really nail this home with my patients. So when we oncologists talk about recurrence, we are talking about the breast cancer that you had that was surgically removed, cells from that cancer coming back at a distant place, which is typically lungs, bones, or liver. Okay. So in other words, metastatic disease. And the whole point of all the treatment that you go through for breast cancer is to decrease risk of it coming back as metastatic disease. Okay. So a lot of people think of recurrence as a new breast cancer, but we're talking about a different thing. It's really unusual for your cancer that you had to come back in your other breast. It's also not that likely to get a second breast cancer. The thing that is the most life-threatening is for your cancer to come back as metastatic disease. Once that happens, we can't usually cure it. So that's why that's why you go through all this stuff to really avoid that as much as possible. Stuff meaning chemotherapy, radiation, surgery, and endocrine therapy for those with hormone-positive breast cancers. So anyway, so a common question is, should we be doing routine scans to look for spread of cancer? And is a national guideline that is not recommended to screen with CAT scans and bone scans to look for metastatic disease. And why is this? Well, we have data on this. So there was a big study that looked at patients who got intense surveillance with CAT scans and labs, and there was no difference in length of life, or what we call disease-free survival, length of life without diagnosis of recurrence, and those who got the scans and those who didn't. The other thing is that most women are cured of breast cancer. So it just ends up leading to a lot of testing, cost, radiation exposure with CAT scans that you don't need. And then every time we do a scan, there's a risk of false positives where we see something else in the scan and we have to chase after that. And that can lead to a lot of costs and unnecessary biopsies and stress and things like that. So the data shows that it's not worth it to do those things. Now, what's different question is, if you're having symptoms that we can't explain, then we would do a scan to look more closely. And I'll talk more about that in a minute. Some of you may know about what are called tumor markers. These are blood tests that are a little bit more old school, or sometimes we use them in metastatic disease. But a long time ago, oncologists were using these to screen for recurrence. The two main ones are called CA 15-3 and CA 25-27. And these are no longer recommended also in national guidelines. And that's because they're just not that reliable. So a lot of things can influence them. They can go up, they can go down, and it just leads to unnecessary stress. They're just not that accurate. So recommended to not do that unless you have metastatic cancer. And then what's new on the scene is something called ctDNA, which some of you may have heard about. This stands for circulating tumor DNA. It refers to DNA that your tumor may have been shedding into your bloodstream. There is a test that's on the market now called Signatera, where you can do a simple blood test to look for this circulating DNA from a tumor. This is a very hot topic. It probably is up and coming, but right now we don't have any data on how to use this. So let's say you're in remission and we're doing this periodically, and then all of a sudden your DNA turns positive. We think you have some tumor DNA floating around in there. What does this mean? Well, we have no idea what it means. We don't know if that means we should start you back on treatment, if we should, then should we be doing imaging? We just don't know. And so there is a lack of data on this, but this is a hot topic of research, so we're going to be seeing a lot more of this. So I have not yet started doing this in my practice because I think it adds to a lot of anxiety, and I, as your doctor, don't know the best way to use it. Okay, so if we're worried about cancer coming back, which we all are, you know, as an oncologist in the survivorship period, one of my main purposes is to always, when I'm seeing you in follow-up, to be looking for any signs that your cancer could be coming back, even if you're low risk. So the symptoms are the number one thing that matters the most, and looking out for recurrence of cancer or metastatic disease. So if you ever have shortness of breath that is new, a cough that's not going away, that's out of the ordinary, unexplained weight loss, or all of a sudden you lose your appetite for no reason, bone pain, especially in one part of your body that's not going away, that Tylenol or Motrin's not taken care of, persistent abdominal pain, or persistent or severe headaches and vision changes. These are all things you should see your oncologist for. So even if you're on a 6-month plan, if you have something like this in between, give them a call and say, hey, I'm worried about this. It's really, I know everybody goes through this where after you have had your cancer treatment, you know, a lot of people struggle with, oh gosh, I hurt my shoulder, and so I'm really worried I have a metastasis there. And so this can be really difficult emotionally to think through. And so what I tell my patients is, you know, if you're worried, just call me. Let me be the one decide if this is something we're worried about or not, to kind of take that pressure off of you, because it is really difficult to handle. Now, you know, every time you get a cough or every time you get COVID, you know, it's not from cancer. So, but if it's something that's lingering, then definitely get a chest x-ray. And I guess what I mean is just don't blow off your symptoms. It's true that hormone positive breast cancer, unfortunately, can come back 10 or 20 years later. And what I hate to see is when I have a patient show up who had breast cancer a long time ago, who we now know she has metastases in her lungs. She said, oh, I was seeing this doctor and I went to urgent care and they just kept giving me antibiotics and no one checked a chest x-ray. Well, if they had called me, I would have checked a CAT scan or a chest x-ray right away. So just be your own best advocate and just don't blow off symptoms that are out of the ordinary. And so if you have any of these symptoms like bone pain, then I would do a scan of that area, or I mentioned the chest x-ray. So that's when I would do more imaging. Okay, what is the good news about breast cancer? 90 to 97% of women with early stage breast cancer are cured. So that is an amazing cure rate. We're getting better and better. I mean, new data is coming out in breast cancer all the time. So it's so exciting. And that is excellent news. So the bad news is there, as we all know, there can be side effects and some late effects. And so a late effect is a side effect that occurs or lasts months to years after cancer treatment. And all of the treatment that we use for breast cancer can cause long-term effects. So chemotherapy, if you had adriamycin, which is the red one, or if you've had Herceptin, those have an increased risk of causing long-term heart problems. Low, but it's there. And those can be lifelong. Chemotherapy commonly causes neuropathy. Immunotherapy, which we now use in more triple negative breast cancer, can cause autoimmune issues, especially with the thyroid, which can be permanent. Radiation and surgery can lead to lymphedema and scar tissue. So these are kind of like the collateral damage of the treatment for breast cancer. And so it's our goal to manage these as best we can. So these are some common long-term symptoms. I don't want to go into these all in too much detail because I could be here all day, but neuropathy is really common, especially from Taxol chemotherapy or docetaxel chemotherapy. And so most of the time this goes away, but it doesn't always. If you have neuropathy, please talk to your doctor about it, especially if you're still on chemo, because sometimes we'll have to stop chemo early so it doesn't get to be too bad. During treatment, icing your hands and your feet can help prevent this. If it's painful, medications such as gabapentin can help. Physical therapy can help if it impacts balance. Certain vitamins like vitamin B12, vitamin D have not been shown to really help neuropathy. So I'm hoping that in the future we'll get more great medications for this. Lymphedema is something a lot of people struggle with. And so it's important to see your lymphedema therapist, your physical therapist, and wear the sleeves. So many people don't wear the sleeves. They can get into trouble. Fatigue, really common, which can last a while. And I think kind of what goes along with this sometimes is the chemo brain or the fogginess that people talk about. I think the two really go hand in hand. And it's really important to exercise. Exercise is the #1 thing that's been shown to help fatigue. And then sleep. A lot of people have trouble sleeping after treatment for breast cancer. And so I encourage that people work on that. There are some medications we can use for fatigue, but that's typically a last resort. And then joint and muscle aches, if you're on anti-estrogen therapy, these are common. And we have a good study that shows that acupuncture can help ameliorate these symptoms. So ask your doctor about seeing an acupuncturist. And then exercise. I encourage everybody to do yoga as long as you can from an upper body perspective. I think yoga can really help these things. And it's also good for your mind. Hot flashes, everybody struggles with those. We have really good medications for hot flashes, but a lot of people don't want another med. Totally get it. Gabapentin, which is also used for nerve pain, is really effective. You take it just at night for a lot of people. Effexor is an antidepressant, which can help. So if you're also having some mood issues, that would be a good one. And then Ditropan is a old medication that's been used for overactive bladder, which we realized just 5 years ago that it's also really good for hot flashes and doesn't cause that many side effects. So those are usually one of those will work well for my patients. For those of you who don't want to take a medication for it, there's this thing called the chili pillow, which basically is a cold pillow, which can help. And then of course, fans. So those are some non-medication effects. There's also like a chili pad. So some of those things you can make changes to your sleeping setup. Sexual health. So this is something that's often not talked enough about. And I think sometimes people feel awkward. Sometimes doctors feel awkward talking about this too, but it's really important to talk about. So vaginal dryness is so common after chemotherapy as women are going through menopause, if you're on anti-estrogens, and that can lead to painful sex, which can really impact your partnership and your sex life, which is an important part of health. So for those who had a hormone positive breast cancer, we always encourage to try to use lubricants first. Coconut oil can work really well for some people. You can make coconut oil ice cubes and insert one every day, and that works really great for some people, and it's natural and cheap. There's also this gel called hyalogen gel, which is made from hyaluronic acid. That's usually my next step. If those don't work, what will definitely work, or almost will always work, is a topical estrogen. So basically a cream or insert like a I want to say pill, but like a suppository in the vagina to help plump up that tissue, and that really helps with dryness and painful sex. Now, this has been controversial for a long time because, of course, we say no hormones if you've had hormone positive breast cancer, but we do now have some data that shows that just a little bit, there's hardly any absorption from that area. The inserts are less absorbed in the cream. That's why we prefer the inserts. So it's okay to do that, especially because this is such a big quality of life issue. Some women, due to thinning of vaginal tissue from the same issue, will be more prone to UTIs. So if you find that you're getting UTIs all the time, please talk to your oncologist about it, because it's usually related to vaginal dryness. Some women need to see a urologist for this issue, but having UTIs all the time is a red flag that we need to do something about vaginal dryness. Another issue in sexual health is body image. So I encourage you to talk to a counselor if you're having some difficulty with that. Sometimes couples counseling is needed for that. And yes, just don't be afraid to bring this up with your doctor. Pregnancy and fertility, just looking at time here. I think I need to speed up a little bit. But there's so much good information. So this is an exciting time for pregnancy and fertility. You know, a lot of women diagnosed with breast cancer are young and have not completed their families yet. So there's this great new trial that was just resulted at San Antonio Breast Cancer Conference this December. Really well done trial. What they did was they looked at women who were 42 or younger with early stage breast cancer, stage 1 to 3, those who had hormone positive breast cancer. So, and they received their endocrine therapy, so their anti-estrogen therapy, for 18 to 30 months. And then they were allowed to stop for 2 years to conceive, get pregnant, carry the baby, deliver the baby. And then after those 2 years, they resumed endocrine therapy. And they compared this group of women to historical controls from all of our other data on breast cancer who did not take a break in their endocrine therapy. And there's no difference in recurrence rate. So now we can really say this is probably safe. Now, I will say that most of the women in the study were earlier stage 1 or stage 2. So I don't know if I'd recommend this for my stage 3 patients yet. In this group, 74% were able to have at least one pregnancy, 64% had at least one live birth, which is similar to rates of the general public. And then after the break, 76% of patients resumed endocrine therapy to complete their 5 or 10 years or whatever. So this was really, really good news for those who want to have a baby. Because I think before this, a lot of us would say, you know, we're kind of nervous about stopping your endocrine therapy. And then women were really faced with this choice of, do I want to take care of my own health or, you know, have a baby? So it's been tough. So this is amazing data for us to have now. Flip side, contraception and hormone usage. So besides the vaginal estrogen I just talked about, any hormones, including testosterone, are contraindicated in women who have had hormone positive breast cancer. If you've had hormone negative or triple negative, it's still a little bit controversial, but it's usually okay, in my opinion. So this can be difficult sometimes because, especially in Austin, hormones are all the rage. I see so many people, especially also women, who are on testosterone. The problem with testosterone is it is converted into estrogen in the body. So taking testosterone is just like taking estrogen. So in women who need contraception, best to have contraception that does not include any hormones. So use condoms, you can get a tubal ligation, copper IUD, or sometimes the partners can step up and do something for contraception and do a vasectomy. It's really important if you're on tamoxifen to not get pregnant on tamoxifen because it's teratogenic, which means it can cause birth defects. So I recommend if you do want to get pregnant to stop it at least 3 months before you start trying. So you do not want to risk that. Trying to think if there's anything else I wanted to say on this topic. Don't think so. Bone health. So endocrine therapy, which is anti-estrogen therapy, and chemotherapy can increase the risk of osteoporosis. And that's really important because we want you to have healthy bones for the rest of your life so you don't get a major fracture, because a major fracture really impacts your mobility. So we typically do bone density scans every 2 years to look at your bone density. Important to take calcium and vitamin D. I have the doses up there. Weight-bearing exercise can also really help your bones. And then for those on endocrine therapy and who have osteoporosis or pre-osteoporosis, which is called osteopenia, your doctor may suggest a medicine called a bisphosphonate to counteract those medications and strengthen your bones. Genetic testing, this is revisited in the survivorship period. Now, in case some of you don't know, most women with breast cancer now qualify for genetic testing, or even if you don't, it's now only about $200 if you want to pay out of pocket. If a gene mutation is found, it may impact your cancer screening for other types of cancers and the risk of cancer in family members, including men. So you can see in this graph here that BRCA1 and 2 is the most common types of mutations in young women with breast cancer. PALB2, which is kind of we're thinking now is basically very similar to BRCA. CHEK2, ATM are the second most common. I see those quite a bit. The other thing I want to bring up, which is new, is that regardless of a genetic mutation, if you have anyone in your family with pancreas cancer, first or second degree relative, even if you have negative genetic testing, talk to your oncologist about it, because there are new guidelines that say if you have, depending on your genetic signature, if you have a first degree relative and a second degree relative with pancreas cancer, then that puts you into a higher risk category for pancreas cancer. And we are now doing pancreas cancer screening, and this is a new thing. So if any pancreas cancer in your family, discuss that with your doctor. Okay. Risk of heart disease. Okay, so this is an important, really important point. The #1 killer of women who have had breast cancer is not breast cancer. It's what we're all focused on, but it's not breast cancer. The #1 risk of death in women who've had breast cancer is heart disease. And some of the medications we use to treat breast cancer can impact your cardiovascular risk factors, especially your cholesterol. So also risk of diabetes and high blood pressure are increased in women with breast cancer. So really important for somebody to be looking at this for you. And usually that's not your oncologist. So this is the reason to really be hooked in with your primary care doctor, so that they're checking for diabetes, they're checking your blood pressure, they're checking your cholesterol. A lot of my survivors want me to be doing these things, but I'm really not well trained to be treating these things anymore. And most oncologists aren't. So this is the biggest reason to really see your primary care doctor. Because remember, the whole goal is overall health. We want you to be cured of your breast cancer, but then we want you to be healthy from a heart disease perspective as well. It's another reason why it's important to exercise and maintain a normal or a healthy weight. So here's an example of a medical follow-up plan for survivorship. So history and physical with your oncologist every 3 months for 1 or 2 years, and maybe every 6 months for 3 additional years. After 5 years, some oncologists are then letting their survivors graduate to their primary care doctor. Others want to follow their patients longer, and that may depend upon your risk. Annual mammogram, which we talked about, physical exam, breast exam is important. We talked about the heart disease screening, and then make sure you get your immunizations, your flu, your pneumonia vaccines, Tdap, now all the COVID vaccines. And then from an overall screening perspective, here is what is typically recommended for women. So mammogram, breast exams by a provider every 6 months, monthly self-breast exams. When you're doing that, look in the mirror too, because sometimes you can't really see or feel under your breast. So look in the mirror and really get a good look under there. Look for any skin changes, especially any red lumps on your skin or anything that looks like a bug bite that's not going away. Colonoscopy is now recommended at age 45. Typically, we repeat that every 10 years, but your GI doctor may recommend more frequently. We talked about the bone density scan. Skin exam can be done by your PCP or a dermatologist if you're high risk. Pap smears, don't forget about those. Dental exams, eye exams if you need them. If you are a smoker or have been in the past, please ask your doctor about lung cancer screening, which is now approved. And then, any other screening recommendations are personalized. So now we're going to talk about healthy living, how to maximize your overall health. Of course, do not smoke. Don't be around people who smoke. Exercise is so important. We're going to talk more about that in a second. Wear sunscreen, limit alcohol, don't do drugs, eat a healthy diet, maintain a healthy weight for you, and get your screening. So alcohol, surprisingly, alcohol is not good for us. That whole thing in the past about alcohol being good for heart health, or red wine being good for your heart, turns out that's not true. That was just wishful thinking. And so the CDC now recommends 1 drink or less in a day for women. I typically recommend, 3 to 5 drinks per week for women. We just have more and more data that alcohol is a carcinogen, increases risk of cancers, increases risk of depression, osteoporosis, liver problems, and chemotherapy-related heart disease. So alcohol is not healthy. Here are the cancers that are associated with drinking alcohol. And I think this is, pretty much new data. It does increase your risk of breast cancer by a little bit, 1.23-fold risk. Otherwise, it's typically the GI cancers, head and neck, esophagus, and colon cancer. So especially during the pandemic, a lot of people upped their alcohol intake, so time to cut down. And then exercise. Exercise is so, so important. Even if you can do a little bit, it's so much better than doing nothing. We know that exercise is good for your mood, fatigue, pain, sleep, anxiety, self-esteem, your brain functioning, your bone density. And this is all proven by research. So you may wonder, why aren't we all exercising all the time? Well, because it's tough to do. It takes time, especially if you're not feeling great from chemo or your therapy. But any little bit goes a long way. And I always tell patients, if I could wrap exercise up in a pill, some pharmaceutical company would make billions of dollars off of it because it is really effective. So we know that exercise can help prevent osteoporosis, high blood pressure, diabetes, heart disease. We already talked about how important that is. The recommendation is 150 minutes per week of moderate intensity exercise, which is just fast walking. So no one's asking you to run a marathon. If you can add in some light weights twice a week, that's bonus. Exercise is really important in breast cancer. We have more and more data that exercise can decrease risk of recurrence, especially in hormone-positive breast cancer. It can improve breast cancer-related survival. And from the research, the take-home message is vigorous is not necessarily better, but more, meaning length of time, is probably better. And this is independent of BMI. So even if you have a heavier weight than you would like, and you can't lose weight for whatever reason, exercise alone, independent of weight, is really beneficial to your outcomes. I think everybody knows, don't smoke. It harms every organ in the body. So really important to not smoke, and people who smoke are less likely to exercise. Nutrition, this is a hot topic. We do not know that one particular diet is better for decreasing risk of recurrence in breast cancer. There's been tons of research on it. So what we do know is that eating fruits and vegetables is good. We want to limit red meat, limit processed foods, limit processed meats. We have more data that processed meats like hot dogs, salami, like the lunch meats, can increase risk of cancer as well. Limit sugar sweetened beverages, and limit processed foods. I think the ideal diet is probably something that has the most data behind it. It's probably the Mediterranean diet or plant-based diet. I think the Mediterranean diet is probably more achievable. So even though we don't have a specific diet that is the best that we know of, we do have data that shows, especially in hormone-positive breast cancer, women who are able to maintain a healthy weight for them have a decreased risk of recurrence. Okay, I know I'm running out of time here. So emotional and mental well-being is really important. So, and it can be tough, especially when we're talking about fear of recurrence and how your life has changed. So it's really important to lean into your social support symptoms, establish a self-care plan that you can change. It's good to have a coping skills toolbox, like what helps you cope. For a lot of people, that's exercise. or being with friends or family. Mindfulness and meditation can be effective. Prayer. Talk to someone who is not family about your feelings and experience. In other words, a counselor. In my opinion, everyone should see a counselor at least once or twice. Be aware of the online supports and the online chat groups. Sometimes that can just increase stress, but for some people, it's very helpful. So just know what's best for you. Feel your feelings. That's what I tell my kids. And then, if you are really feeling down, if you're having thoughts of hurting yourself, hurting somebody else, if you're thinking about death a lot, please reach out to your care team. The early survivorship period after you finished therapy is the highest risk period for suicide. It's the hardest part mentally and emotionally. So, so please seek out support if you need it. For most people, that early stage of survivorship where they have the most distress does improve. You need to adjust to that new normal. There's new normal right there. Yeah. So what is your new normal? You have to think about your new priorities. Your relationships probably changed. You may be feeling grief about, the loss of how your body was, how your relationships were. You may be struggling with chronic pain, which can be really difficult. Anxiety is real. Fear of recurrence is real. So important to talk about all these things with your counselor or your doctor. And we talked about some of those other things. So here are some resources that are great. So we have resources here at Texas Oncology as part of our survivorship program, our social workers, our support groups. Texas Oncology Foundation is wonderful, and they have a lot of resources. So follow them on Facebook if you don't already. In Austin, we're going to have our Survive and Thrive Symposium in November. If you want to come to that, I think it's going to be at the Westin at the Domain. We had that before the pandemic. We're bringing it back. It's going to be awesome. And then ASCO has some survivorship resources, and here are the other places you can look. So with that, I am looking forward to answering your questions. Thank you for having me today. I hope you all learned something and thought this was beneficial for you.
Thank you, Dr. Hudson. We do have time for some questions. So Dr. Hudson, you want to stop sharing your screen?
Oh, sure.
And we have quite a few questions in the Q&A. So there's a couple about screenings. Can you please explain the difference between a breast MRI and the 3D mammogram with contrast? Will they show the same results?
That is a great question, especially since I know we have some people from outside of the area. Breast MRIs are standard of care. That's what's recommended by the guidelines if you're doing high-risk screening. Now, mammogram with contrast is also a good tool. It's probably up and coming. It just hasn't been studied as much, and it has not made it to be part of the guidelines. So it's probably just as good, but we don't have data to really prove that yet. So so I think talk about it with your oncologist. Some people really hate MRIs, and if you get claustrophobic, they're expensive or whatever, I think a contrast enhanced mammogram is a really good substitute. I'm kind of a by the book person, so I try to do the MRIs for my patients who need them, but I don't really have heartburn if we go with the contrast enhanced mammogram and feel pretty comfortable with that. But if you ask 10 oncologists, you probably get 10 different answers. And I think we'll get more data on that as time goes on.
Great. Okay. The other question was regarding MRIs. Dr. Melinda Jones said that lobular breast cancer is only detected with MRI. She said her mom had metastatic breast cancer, always had a diagnostic mammogram. And had a normal mammogram. So 2 weeks before she had a bone marrow biopsy. So she is now stage 4. So the question is, how would women know to have MRI supposedly, or after all mammograms have been normal?
Yeah, lobular is tough because lobular is a type of breast cancer that doesn't always show up on mammograms. That's why we hate lobular, because it just makes it harder to really get the full sense of the stage. So if you have had lobular, then that might be a case in which your doctor recommends having MRIs going forward. If you have cancer that was diagnosed on a mammogram that was lobular, oftentimes we will do an MRI before your surgery and planning to make sure we know the full extent of lobular. But I think it depends on the case and how well it was seen. But it's not recommended by national guidelines to do MRI for everybody who's had lobular. So I think it's a case-by-case basis.
Okay. I want to, there's a couple of questions about tumor markers. And so one person wasn't sure if you had the wrong CA 2729 or is it CA 2527? And to follow up with that is, are all tumor marker tests not recommended anymore?
So the tumor markers are not, by guidelines, are not recommended unless you have metastatic disease. So depending on your doctor, this is another case, every case is unique. And so I would, if your doctor has a good reason to do it and it's part of their practice, then, I think you should discuss it with them. But typically it is not a standard of care anymore. And I don't use them in my practice. And I can't remember I put in the slide, maybe it was a typo. It was 15.3 and 27.29 are the breast cancer markers.
Okay, great. Thank you for that. So what does bone pain feel like? Is it concentrated in a certain part of your body? For example, will it only be in upper arms, trunk, or to your knees?
Sorry, bone scan, is that what you said?
Bone pain.
Bone pain.
So bone pain. And is it concentrated in a specific part of the body?
Okay, so what we're looking for is, the idea is if you had cancer spread to your bones, it can cause pain. So cancer can go to any part of your bones. It is typically more common to be in your trunk, especially hip girdle, spine, metastases. So not usually your longer bones like your arms or your legs. So, if you have hip pain that's not going away, that you can't explain by like a exercise injury, just ask your doctor about it so you can get it evaluated. Typically, it's pain that's more than what you'd be used to with some kind of exercise injury or throwing at your back or something like that. And typically, like Tylenol or Motrin won't help take it away. And it's also typically a pain that doesn't wax and wane. It kind of is persistent.
How common is hematomacrosis after AC and Taxol? So the PCP found, mine was only found by my PCP who happened to order a ferritin test several years after chemo. Should ferritin testing be included with a routine CBC ordered by the oncologist? So you're probably gonna have to explain what that term is because I could barely even pronounce it.
Ferritin is actually an iron lab. So if we're worried someone has iron deficiency, we'll check a ferritin. That's really the most common reason to check it. But it's one of those tricky, this is getting into the weeds a little bit. It's one of those tricky labs that can also be elevated if there's inflammation or some chronic issue going on. So, and some people who have metastatic cancer, it can be high, but I wouldn't say that would be helpful in most people. I think, and since it can either reflect iron or inflammation, it's just kind of like a murky lab. So I usually check in routine labs, which, by the way, it's not indicated by guidelines to check any labs routinely because cancer will usually, if it's metastatic, will present with symptoms as we talked about. But in my practice, I typically do blood counts, so CBC, liver function, kidney function, and sometimes, if there's bone disease, one of the labs will be elevated. If there's liver disease, sometimes those will be elevated. So if I see a change in the labs like that, then that will prompt me to do more imaging.
I think this is a really common question. Can women with hormone positive cancer ever breathe a sigh of relief?
A really tough one. That's really, really hard. For the HER2 positives and the triple negative, if your breast cancer is going to come back, it almost always comes back in the first couple of years of 5 years. For hormone positive, it can remain latent for a long time. If it's going to come back, it usually comes back within 10 years, but it can come back up to 20 years. And, I hate that because it's very depressing, but at the same time, it's important to know, we're talking about, it's important to be vigilant about these symptoms for a long time. So I think after, my mom had breast cancer at 47, she's now 76. I think she can breathe a sigh of relief. So I think after, 15, 20 years, you can kind of like cross it off the list of things to worry about. But it is very hard, very hard.
Yeah, so that adds to this anxiety and the feeling when you have to go in for your appointments. And but once the treatment after 5 years, how do you keep those fears and that anxiety down? Because majority of cancer patients stop seeing their oncologist after 5 years.
Yeah. I think everybody has to learn to handle it in a way that works for them. If I could say something to take away that fear of recurrence and anxiety, I would. And I think it's impossible. And I think I do think it improves with time. I think you get more comfortable with living with that uncertainty. But it's really about facing your mortality and not knowing what's going to happen in the future. And that is really hard to wrap your head around. So for some people, so what I tell patients is like, if you have a cough and your kid has the flu and you have a cough, you know why you have the cough. It's not cancer. So you just have to do some self-talk and say, this is a virus. This is not cancer. I am okay. And I think mindfulness is also really important, living in the moment. For some people, there are different coping techniques which can really help, talking with other survivors, support groups, exercising, doing what's important to you, at this point in your life. So I think people handle it different ways, but it is very difficult. I do see one thing in the chat. Someone said, I thought tamoxifen increases bone density, and that is true for the most part in postmenopausal women. If you're on tamoxifen, it does typically increase bone density. So I will update my slides. That is a caveat. Sometimes for premenopausal women, it can decrease bone density a bit. So that is the one caveat with tamoxifen.
Thank you. I was going to be my next question.
Oh, okay. I missed it. Sorry.
And so we are out of time. I do want to ask one final question, because I know this comes up a lot. When do cancer patients start seeing their regular doctors, their regular primary care, their OBGYN, any of their other physicians? Because we're followed so closely by our oncologist. I think a lot of cancer patients don't really know when it's okay to, if they have a cold or something comes up, that they can actually start seeing their regular doctors again.
Yeah, so right after you finish your primary treatment, you should go back and reestablish with your primary care, so that they're looped in on the early side. You do not want to wait multiple years before you see your primary care doctor, so that they're screening you for all of those other important things that we talked about, like high blood pressure, diabetes, and cholesterol. So what I typically do is we have the survivorship visit. We have that document that kind of summarizes everything we're going to look out for, et cetera. And then they can bring that, or we send that to the primary care doctor so they have an update on everything that's happened.
Great. Thank you, everyone, for submitting your questions. I'm so sorry we didn't get to all of them, but we appreciate you attending today. Thank you, Dr. Hudson. This was so informative. There are a lot of comments in the chat box about how great the information was. So we thank you for joining us today, and have a great day.
Thanks, everybody. It was my pleasure to be here. Best of luck to all of you on your journeys.